Thank you, Pallavi madam. So we'll start the session now. A very good evening to everyone who has joined us here today for yet another interesting session of Wednesday Wisdom. On behalf of Maha-IAP and Maha-IAP Women's Committee, myself, Dr. Amruta Shirodkar, would like to welcome you all. Today's session is on a very crucial topic of childhood obesity and adolescent obesity. We have recently observed 4th March as World Obesity Day. And we know that childhood obesity not only affects the health of our younger generation, but also has implications later on in their adult life. We already know that like in 2017 there were 14 million obese children in India, and now the prevalence, not only the prevalence but also the severity of obesity is increasing by leaps and bounds, and thanks to the pandemic we have many obese children on the rise. So today's session with 5 young speakers and 2 experts in the field, I'm sure we will try and raise awareness, share insights, and explore potential solutions to combat this growing epidemic. With this, I now take the pleasure of welcoming on board our Maha-IAP President, Dr. Ram Gopal Chejara, sir. I extend a warm welcome to you, sir, and request you to kindly say a few words.
Thank you, Amruta. Good evening, friends. Welcome all. I welcome today's experts, Dr. Tushar Godbole, sir, and Dr. Rahul Jahangirdar. And welcome to all the 5 presenters of the obesity. They would be talking on a different topic of obesity. Now, already we have more than 250 participants. So this success credit goes to the women's wing. So a lot of efforts done by Dr. Manjusha Sherekar and Dr. Gravita Raikar and the whole women's committee. So 3 cheers for the women's committee. And I will not take much time. Let us start the program as early as possible.
Thank you.
Thank you so much, sir.
Thank you.
I would also like to welcome Secretary Maha-IAP, Dr. Amol Pawar, sir. So I would request you to say a few words.
Thank you. Thank you, Amrita ma'am. This year we have renamed this session as Wednesday Wisdom, and under the chairmanship of Dr. Manjusha Sherkar ma'am, Dr. Grivita Raikar and Dr. Amruta Bhaviskar. I welcome Dr. Tushar Godbole, good friend of mine, Dr. Rahul Jagirdar sir, today's experts who have consented and taken a lot of efforts in guiding all the speakers from all over Maharashtra. I welcome all the speakers and all delegates from the team Maharashtra IP also. Central IP President Dr. G.V. Basavaraja has came with some innovative community programs this year, IAP Ki Baat community ke saath, and with this lot of branch office bearers have started community work, and they have gone to various schools and communities explaining the importance of previously last month anemia and this month obesity. So to add on this, Maharashtra IIP has come out with this obesity conclave, I will say, under the guidance of Dr. Bhavesh Mithia, who has selected these 5 topics, and women committee from all over Maharashtra. These zonal executive board members, they have allotted 5 these topics to 5 and speakers. So without wasting time, I straight away ask Amruta ma'am to carry on the session. Thank you.
Thank you so much, Dr. Amol sir. May I now request Dr. Manjusha Sherkar madam. Madam is the chairperson of our Maha-IAP Women's Committee, to say a few words about today's session.
Oh, thanks, Dr. Amruta. Good evening, respected experts, Dr. Rahul Jahagirdar, Dr. Tushar Godbole, Honorable Maha-IAP President, Dr. Ram Gopal sir, Dynamic Maha-IAP Secretary, Dr. Amol sir, MMC Observer, Dr. Prashant Badane, Maha-IAP Women Committee Co-Chairperson, Dr. Grivita Raikar, Women Committee Convener, Dr. Amruta Bhaviskar, Scientific Convener, Dr. Bhavesh Mithia, and all the zonal women committee members, esteemed OBs and EBs of state and central IIP, and dear all viewers. On behalf of Maha IIP and Maha IIP Women Committee, I welcome each one of you. We feel very proud to present before you total 5 talks, which will be deliberated by young and dynamic speakers from all the 5 zones of Maharashtra. And they are Dr. Daina, Dr. Sachin, Dr. Satish, Dr. Madhur, and Dr. Drakshayani, who all are wonderfully guided by our experts. So the entire team here is to address the critical issue, that's childhood obesity, the epidemic which not merely a concern for today, but it casts a shadow over the future health of our adolescents, taking them towards various non-communicable diseases. And it's a time to recognize the power we hold to enact the change. Time to empower the opportunity as a pediatrician to shape healthier environment for our children. I assure that you will get an excellent take-home messages through today's Wednesday Wisdom program. Together, we ensure that every child gets his right to grow happy, healthy, with his full potential. Thank you so much. Over to you, dear Amruta.
Thank you so much, madam, for those kind words. I also acknowledge the presence of MMC observer Dr. Prashant Bhadne sir for today's session. Participants are requested to post their MMC registration number and their names into the chat box. Also, if you have any questions, please post in the chat box if time permits, and if they are not already answered by the experts, we shall be taking them up. With this, I think we will now start with the science. So I would now firstly request Dr. Manjusha madam, who is also co-moderating the session with me today, to first introduce our experts, and then we'll start with the science with the first session. Over to you, madam. Madam, please unmute yourself.
Manjusha madam, unmute yourself. Pallavi, can you unmute Manjusha madam?
नाही सर, त्यांना परमिशन आहे ऑलरेडी.
पण त्यांना ऐकू येत नाही बहुतेक, तर ऍटलीस्ट इफ यू कॅन अनम्यूट.
मंजुषा मॅम, कॅन यू अनम्यूट युअरसेल्फ प्लीज?
Yes, I did. So let me introduce today's first expert, Dr. Rahul Jahagirdar sir. Sir is a senior pediatric endocrinologist and professor at Bharati.
Madam, sorry to disturb. Amol sir is saying something.
Yes, Dr. Amol.
Unmute Amol. Amol, unmute.
So that is muted from office only.
Continue the session. Yes.
Okay. Welcome, Dr. Rahul Jahagirdar. Sir is a senior pediatric endocrinologist and professor at Bharati Vidyapit University Medical College, Pune. He holds his 30 publications in national and international journals. He is a guide for pediatric endocrinology fellowship and 5 book chapters on his name. Hearty welcome, Dr. Rahul Jahagirdar, and thanks a lot for guiding our speakers as today's experts. Welcome, sir.
Thank you so much.
Yeah. Now let me introduce our second expert, Dr. Tushar Godbole, a young dynamic pediatric endocrinologist. Sir is a director of Harmony Health Hub, Nasik. He is associated professor of Vasantrao Pawar Medical College and Hospital, Nasik. He is a visiting consultant at Chhatrapati Sambhaji Nagar and Dhule. He has book chapters in GAI textbook of pediatrics, IIP book textbook of pediatrics, and PG textbook of pediatrics. He has 4 national and 5 international publications. He is a EB member of ISPAE 2015 and 1920. He was an editor of MahaIP Bulletin 2015 and 16. He is Sarla Vaishnav Awardee for the best research paper in metabolic diseases. And very special mention that Dr. Tushar is a very good melodious singer. So welcome such a dynamic expert. Hearty welcome, Dr. Tushar. And let us not waste much time and start the scientific session. And for the first talk, I call again D for dynamic, Dr. Daina. I invite Dr. Daina, our first speaker, as an excellent orator who is a consultant pediatrician from Thane attached to Bethany and Jupiter Hospital. Dr. Daina will talk on definition, change in epidemiology, rising incidence, recognition and etiology of obesity in children and adolescents. Over to you, Dr. Diana. Please start sharing your screen.
Thank you, Dr. Manjusha. Good evening, each and everyone, all the dignitaries here. I thank Maharashtra IAP Women's Committee and Maharashtra IAP team for giving me this wonderful opportunity to come on this dais and share these, talk on this important topic. So let's just start with the presentation. Is it clear? Is the slide visible and am I audible?
Yes.
Thank you.
You
Okay.
could be a little bit louder, Diana,
Louder?
little
Okay.
bit.
Yeah, sure. So to begin with the topic, obesity, we'll be first introducing ourselves to obesity, the topic that we already, all of us know and practice very well. Just to brush upon once more, because the eye sees what the mind knows. So we have to keep revising. So we see them and we pick them up. As ma'am very clearly said that it is an epidemic, it is an unrecognized pandemic, I would rather say, which is going around, and we as pediatricians need to pick them up from our regular OPDs. So to begin with the definition of obesity, we have two definitions for children above 2 years and children below 2 years. For children above 2 years, we have the BMI charts, which we all know, which is weight in kg upon height in meter square, where BMI for overweight is taken as anything more than 23 kg per meter square. And for obesity is 27 kg per meter square. Extreme obesity has been added up considering the existing incidence and growing rates of the weights of the children. So extreme obesity is BMI more than 120% of the 95th centile, or absolute value of more than or equal to 35 kg per meter square. Below 2 years of age, we take weight for height or weight for length, which is recently added according to our IAP standard treatment guidelines in 2022. It says anything more than 97.7 percentile, which suggests obesity. Basically, it is those two standard deviation above the 50th centile. If it is between second and third standard deviation, we take it as overweight, and anything more than third standard deviation above the 50th centile is taken as obesity. The changes that of late we have all been seeing in our OPDs, but the numbers, the statistics are really very worrisome. From 1990 to 2022, if you look at the numbers, adolescents age 5 to 19 years, the obesity has increased fourfold from 2% to 8% all over the globally, all over the earth world. So, but among this, more worrisome is 1 in 10 obese children is from globally is found in India. So we all need to be really alert, looking out for these kind of children in our OPDs. If you see the numbers, over 250 million kids are expected to be obese by 2030. By 2020, there were 158 million. 2025, we are expecting 206, and the number rises to 254 and above by 2030. This is given by the World Obesity Foundation Atlas of Childhood Obesity. Current statistics, if you see, according to WHO, by 2022, 1 in 8 people in the world, this is including obesity, were living with obesity. If you see adult obesity, it has doubled since 1990, but adolescent obesity has quadrupled. Now, this is the younger generation who is going on to be the next global population. So that is a quadrupled, so it's an alarming number. If you see under 5 age children, 37 million children were overweight. And between 5 to 19 years age children, if we see, overweight children were almost more than 390 million children by 2022 itself. Just to briefly touch upon types of obesity, my colleagues ahead will be talking in detail about this. But just to touch on this topic, we have exogenous obesity and we have endogenous obesity grossly. Talking about endogenous obesity first, which is there are different types of endogenous obesity, like monogenic obesity, where single genes are involved, the most common being MC4R gene, which is melanocortin 4 receptor gene, which has its own typical findings. Early presentation, the baby sitting on the chair next to our point of monogenic obesity is typically child with MC4R gene, which is less than around 2 years. They start presenting early hyperphagia, early onset obesity, and they do have some developmental delays. So that's how they present. Every syndrome has a different presentation. Obesity syndromes, we have a couple of them, which we will come to in the next slide. Hypothalamic obesity is another type where we look for certain neurological symptoms associated with hyperphagia. Drug-induced obesity, as we all know, steroids and certain anti-epileptic drugs like valparin and all cause obesity. Endocrine obesities, of course, hypothyroidism, Cushing's, these are all very common causes, commonly causing obesity. Psychological causes is again nowadays an upcoming thing. Somebody is very depressed, he goes and eats. Somebody is very happy, he goes and eats. So eating has become, and eats, unfortunately, what they get is chocolates and junk, and all this comes the first thing. So that is another leading cause of obesity these days. And exogenous obesity, that baby is so cute, but exogenous obesity is not so cute really. We need to look at it, we need to address it, and we need to bring it in front of the parents that child is just not healthy, but he is getting into overweight and obesity criteria. So we need to start working on this as early as possible. So some clues, as I was saying, in our regular routine busy OPD for many of our seniors rather. So just to pick up the children with some syndrome, so that we can give some reference to endocrinologists, we can involve certain other department people, so that child is holistically managed. So certain features which we can see in the OPD are delayed puberty, which will point towards Bardet-Biedl and Prader-Willi syndromes. Retinitis pigmentosa, polydactyly, point towards Alstrom and Bardet-Biedl syndrome. Short hands and feet typically is seen in Prader-Willi. Buffalo hump, stripe, plethora, hypertension, as we have been seeing since our MBBS days. Steroids, Cushing syndrome cause this kind of obesity. Short fourth metacarpal, I always remember my teacher used to look at every child with obesity who used to come to our endo OPD. She used to look at this. So she said, fourth metacarpal is okay. Pseudo-hypoparathyroidism nahi hai. So that is very typically of pseudo-hypoparathyroidism. Developmental delay guides us towards Prader-Willi hypothyroidism and pseudo-hypoparathyroidism again. So etiology again, which we all know, diet is the most common, sedentary lifestyle is the most common thing, which we as pediatricians have to look into and counsel each and every child who is into overweight category as well. Sleep deprivation nowadays, stress disorder, mental disorder, stress for a 2-year-old, 4-year-old, 10-year-old is all there. So we cannot ignore that saying, "Arey 2 saal ka bacha hai," there wouldn't be any stress. It's not that. So that has to be acknowledged. Genetics again has to be looked into. Gut bacteria is a new thing that is coming up causing obesity. So a lot of probiotics, lot of studies being done on this, but it is an important topic important reason for obesity. Medical drugs, of course, we know. So for that green boy from left, move to left to right, what he needs to do is he needs to do a lot of physical exercise. He needs to avoid stress and he needs to have a healthy diet. And if we have certain specific syndromes or specific reasons for these kind of obesity, we as pediatricians have to give a holistic treatment to these children. What we should not do after doing all this, we should not be on a seafood diet. So what is a seafood diet? I see food and I eat it. So this kind of a diet is not recommended. And all jokes apart, but since very genuine topic, it's very I take it very seriously. And to every child who comes in my OPD, I'm sure we all do it, but we should be more and more talking and making parents more aware about it. So with this, I think with that cute little thing saying bye, I would also like to say thank you to each one of you for patient listening and for giving me this opportunity. If there are any questions, I would like to take up. And I also want to thank Dr. Rahul, sir, for guiding me through while preparing this presentation.
Yeah, that's wonderful, Dinah. Hearty congratulations. You had given a wonderful overview and good deliberation. And I really like that seafood diet, something for new. It's very good. Thank
Stop
you.
sharing the screen, Dinah, please.
Now I request our expert, Dr. Rahul Jahagirdar, sir, to give his comments and value additions to the topic. Over to you, Dr. Rahul.
Thank you, Madam. Dr. Dana, for a very wonderful presentation.
Thank you.
Just a few points as take-home messages after your presentation. Am I audible?
Yes.
Yes,
Yeah.
sir.
So if you talk about the growth charts, this is for trainees and the new pediatricians who are just budding. The IIP growth charts are used between 5 to 18 years of age. Okay. And less than 5 years of age, we use the WHO charts. The IIP charts have a BMI charts. If you have a look, or if you have them with you, you can have a look. The new charts now have 2 lines. One is red and the other is orange. The orange line corresponds to 23rd adult equivalent, and the red line corresponds to 27th adult equivalent, which has been modified. Previously, we used to say 85th percentile, 95th percentile as overweight and obesity, which corresponded to 25th and 30th BMI standards. Now they are modified to 23rd and 27th because we Asians are shorter and tend to have additional abdominal fat, which predisposes us to metabolic syndrome at a lower BMI. Hence, we have modified it to 23rd and 27th adult equivalent, which are used as cutoffs for overweight and obesity respectively. Below 5 years of age, even the IAP recommends use of WK charts. And here we use weight for length or weight for height charts. Again, if you look at them, there is a red and orange line, which corresponds to +2 and +3 standard deviations. Anybody who between +2 to +3 standard deviation is considered as overweight, and more than +3 standard deviation is considered as obese. This was a brief overview of the growth charts. Secondly, she rightly covered the classification as exogenous and endogenous obesity. One should remember, most common cause of obesity is exogenous, which is almost 90% of the conditions come as exogenous, and only 10% of them come as endogenous causes. When we think of exogenous, it can start right from the preconceptional time when the maternal illnesses like diabetes, maternal drugs, maternal obesity to begin with can lead to a child who is obese. Parental factors like feeding in the way of complementary feeds, lack of breastfeeding, excessive feeding, introduction of formula feeds can again predispose a child towards obesity. In addition to that, lifestyle modifications, sleep disorders, screen time have a role to play, which I'm sure we'll discuss as we go ahead. And endogenous, like we rightly said, includes a lot of conditions. But remember, endocrine causes are not the most common cause of endogenous obesity as well. They form less than 1 to 1.5% of total causes of obesity. Syndromes, yes, there are a lot of syndromes, and they do have a particular character which will be picked up and can give you a clue along with the use of growth charts to diagnose those conditions. I'm sure the next speaker would cover them in detail. So I think I'll stop at this and allow the next speaker to take over. Thank you, ma'am.
Manjusha madam, unmute. Manjusha madam, unmute करा.
मॅडम ट्राय करा आता. मॅडम ट्राय करा.
Yes, thank you. No, I did. That is not happening with. I think she has muted everyone. So thank you, Dr. Rahul Jagardar sir, for excellent review. Really, we should remember first 1,000 days. Start from antenatal period since the baby is getting conceived till first 2 years is very important to look into. The nutrition is very important. Thank you so much. Now let's see for the second speaker, Doctor. I invite Dr. Sachin Wahadne. Dr. Sachin, you are there? Yes. Dr. Sachin is consultant pediatrician from Ahmednagar, who is a president of IIP Ahmednagar 2024 and is associate professor at Padma Shri Vikhe Patil Medical College, Ahmednagar. Topic given to him is clinical and laboratory evaluation of obesity, including risk factors. Over to you, Dr. Sachin. Can I request you to share your screen, please? Dr. Sachin, unmute yourself. Dr. Sachin, unmute yourself. Dr. Pallavi, please allow him. Dr. Pallavi, sorry, Pallavi ma'am.
Yes, ma'am. Yes, ma'am. Yes, ma'am. झालंय.
Yes, Dr. Sachin, please.
Yes.
Good evening, everybody.
Sachin sir, full screen करा, full screen.
Full screen.
Full screen नाही झालंय का? नाही झालंय full screen?
नाही.
Nice. Double click कर.
नाही होते.
परत
सर प्रेझेंटेशन तुम्ही सर प्रेझेंटेशन बंद, शेअरिंग बंद करा.
हाँ.
प्रेझेंटेशन फुल स्क्रीन करा आणि परत शेअर करा, होईल.
एकच मिनिट.
शेअरिंग बंद करून टाका सर. येस, आता परत शेअर करा सर फुल स्क्रीनची विंडोला. वरती अॅनिमेशनच्या शेजारी स्लाइड शो म्हणून ऑप्शन आहे ना सर, त्याला क्लिक करा. होम इन्सर्ट डिझाईन अॅनिमेशनच्या शेजारी स्लाइड शो, त्याला क्लिक करा.
ओके.
आणि फ्रॉम फर्स्ट स्लाइड त्याला क्लिक करा.
येस, दिस इज फर्स्ट स्लाइड.
नाही,
पण फुल स्क्रीन नाही झालंय सर अजून.
फुल स्क्रीन माझ्याकडे झालंय.
सर
स्लाइड शो.
सर आता हे क्लोज करा, शेअरिंग स्टॉप करा.
हा.
इकडं फुल स्क्रीन आधी करून ठेवा आणि मग नंतर शेअरिंग करा.
ओके 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 ओके. जस्ट अ मोमेंट.
आधी फुल स्क्रीन करून ठेवा तिकडं.
शेअर करताना आहे ना सर, फुल स्क्रीनची विंडो सिलेक्ट करा फक्त. ती स्मॉल वाली शेअर झाली तर तीच दिसते फक्त.
आपल्याकडे बॅकअपला आहे का मॅडम?
नाही, माझ्याकडे नाहीये सर. माझ्याकडे मधुर मॅडमचं आहे फक्त.
अमृता हैस?
हा मॅडम.
मगाशी
have backup?
होतं, आता का बरं नाही?
PPTs.
शेअरिंग केलं का तिकडे सर फुल स्क्रीन?
एकच मिनिट झालं, फुल स्क्रीन केलंय.
आता शेअरिंग करा. नाही झालं तर मग व्हॉट्सअपला मला पाठवा, मी पल्लवी मॅडमला पाठवतो. पल्लवी मॅडम शेअर करतील.
ग्रुपवर टाका सर, ग्रुपमध्ये मी आहे.
हा, ग्रुपमध्ये टाकलं तरी चालेल. शेअरिंग नाही होते का सर?
नाही ना, शेअरिंग नाही होतंय.
सर तुमच्या व्हॉट्सअपला आहे का प्रेझेंटेशन?
मी हे करतो.
नेक्स्ट स्पीकर देन.
थांबा थांबा थांबा.
सर मी काय म्हणतो, नाही झालं तर काय फरक पडतो? फुल स्क्रीन इट्स ओके. दिसतं सगळ्यांना.
हा, ठीक आहे. इट्स ओके. इट्स नॉट फुल स्क्रीन ऑल्सो, नो प्रॉब्लेम. येस, गो अहेड सर.
करा शेअर तुम्ही. सचिन सर करा शेअर.
ओके, नाव इट्स विजिबल.
Yeah,
Yes.
it's okay. It's okay.
Okay.
Please go ahead.
Please start, sir.
Yeah.
Please start. Thank you.
Good evening, everyone. I thank all the office bearers of Maharashtra IIP, the senior pediatric endocrinologists who are our mentors and guides for today's session, and all the office bearers of the IIP Maharashtra Women's Wing for giving me this opportunity to participate in this wonderful CME on obesity. My topic for today's presentation is clinical examination, laboratory evaluation in obesity. Actually, the evaluation of patients with obesity has got three parts. First is the evaluation on the basis of history, then on the basis of clinical examination, and the laboratory evaluation. First, as per the different causative factors involved in obesity, we'll have to evaluate the patient on the basis of history first. We'll have to take dietary history in detail. Basically, diet rich in carbohydrates, fats, energy-dense foods, then lack of breastfeeding, then early introduction of complementary feeds, etc., are important causes for development of obesity in later life. Then, in case of physical activity, the patient is usually having history of decreased physical activity, sedentary habits, more screen time, then sleep irregularities. Then also the birth history is also important. The birth weight, IUGR, postnatal events are also important in the development of obesity in later on life. Then antenatal life, as madam has already suggested, that first 1000 days of a kid's life are important for future development of obesity. The maternal pregnancy, overweight, gestational diabetes are also important for obesity development in little life. Then menstrual history of adolescent girls, where the menstrual irregularity, hirsutism, acne can be there. On the basis of history, we can diagnose PCOS in these cases. Then family history, the obesity and associated complications like hypertension, heart disease, eating habits, and behavioral pattern in the family has also a bearing on the future development of obesity. Then the developmental history is also important. to rule out any chromosomal or genetic syndromes, like developmental delay will be associated with that. Then drug intakes. Some certain drugs are known to cause obesity in children, like steroids, olanzapine, risperidone, like anti-epileptic drugs like valparin. Then psychological assessment of the kid on the basis of history is also important in case of obesity. Then hypothalamic obesity cases, we'll have to look for history, which is suggestive of CNS infections, some traumas, some space occupying lesions, etc. Then some shortness of breath, exercise intolerance on the basis of history, which can indicate presence of asthma. Then again, PCOS history. Then this snoring, sleep disturbances, morning habits, headaches, daytime somnolence suggest obstructive sleep apnea, which is after effect of the obesity. Then hip, knee, or back pain. There can be a case of slipped capital femoral epiphysis due to the overweight or obese children. Then abdominal pain, which is suggestive of GER, constipation. Sometimes non-alcoholic fatty liver disease can be diagnosed. Then a recurrent headache, cases of pseudotumor cerebri, rarely. Then we come to clinical examination of these kids with obesity. The most important factor or most important part of clinical examination would be the anthropometry. We'll have to take the weight of the child, the height of the child. Then we'll have to calculate the body mass index of the child, mid-parental height of the child. Important factor is body mass index. As the previous speaker, Dr. Diana, has already elaborated on this. In 5 to 18-year-old Indian children, the BMI cutoffs are 23rd adult equivalent and 27th adult equivalent to define obesity. This is modified in case of obese Indian or Asian children. For Western kids, it is 25 and 30 adult equivalent. In children, and here we use IAP 2015 BMI charts. And in children under 5 years of age, the child whose weight for length is more than or equal to +2 standard deviations, but less than +3 standard deviation is diagnosed as overweight, and value more than or equal to 3 standard deviation is diagnosed as obese. Here we use WHO charts. The one more important measurement in association with the BMI would be waist circumference. It is waist circumference is very important along with BMI, because if we use only BMI, 25% of the kids with normal BMI will be missed, who are overweight or obese. And if we combine waist circumference along with BMI, then these 25% children will also be diagnosed. Why this happens? Because the waist circumference is important, and it is raised in case of central adiposity, which is very common in Asian and Indian children. And in Indian children, the waist circumference greater than 70th percentile can be used as a cutoff for identifying children with central adiposity who are at risk for developing metabolic syndrome. We have got India-specific charts for waist circumference, which we can use as a reference. The other factors or other clinical examination points would be body fat distribution is important. Waist circumference, it is usually measured in a standing child at the uppermost point of the right iliac crest horizontally with a non-stretchable measuring tape. And the figure is plotted on the India-specific waist circumference chart. If it is more than 70th percentile, then it is diagnosed as overweight and obese. Then we'll have to also do sexual maturity rating in these kids. Lipomastia and buried penis will be there. Micropenis, undescended testes, if it is there, then it is suggestive of Prader-Willi syndrome. Then delayed and precocious puberty will be there. Moon faces, buffalo hump is suggestive of Cushing's syndrome. Then we'll have to take blood pressure measurement in these kids. These kids are very prone for hypertension development. Then skin examination will give clues about acanthosis nigricans, which suggests insulin resistance. Then some clues towards PCOS like hirsutism will be there, striae will be there, skin tags will be there. Then hair, dry and brittle hair are present in hypothyroidism. Then some dysmorphic features can also be seen on clinical examination. Then some skeletal components like limp and bowing of legs, which are after effects of the obesity. Then there can be hepatomegaly in case of non-alcoholic fatty liver disease in kids with obesity. Then one important lab parameter. We'll come to the laboratory evaluation of obese children. One of the most important laboratory tests which we do in obese children is fasting lipid profile. And these are the cutoff values which are provided, which suggest abnormal lipid profile in case of obese children. The total cholesterol value, if it is more than or equal to 200, it is significantly abnormal. LDL more than or equal to 130 is significantly abnormal. Then non-HDL cholesterol more than or equal to 145 milligram per deciliter is abnormal. Then similarly for triglyceride, there are different ranges for 0 to 9 years. If it is more than or equal to 100, 10 to 19 years, if it is more than or equal to 130 milligram per deciliter, and HDL cholesterol, if it is less than 40, it is significantly reduced, and it indicates dyslipidemia in case of obese children. And other lab parameters which we have to look for are the SGPT or the liver function test, then renal function test, then fasting blood sugar levels we'll have to see, then oral glucose tolerance test to diagnose underlying diabetes. HbA1c is used to measure the long-term blood sugar levels. Then in case of hypothyroidism, usually as per the IIP guidelines, the endocrine abnormalities or the thyroid function tests are to be done only in obese children who are short. Only in short statured children with obesity, we suspect hypothyroidism, and usually endocrine assessments are usually restricted to these kind of kids. So hypothyroidism, if it is suspected, in TSH and free thyroxine will be there. Then slight increase in
Dr.
the level.
Sachin, you have 2 minutes left.
Yes, ma'am.
Yeah.
Slight increase in TSH can be expected in some obese children because of the peripheral resistance to the TSH. Then in case of Cushing syndrome, we can do its tests like serum cortisol and all. Then growth hormone deficiency, we'll have to do IGF-1, IGF binding protein 3. Pseudohypoparathyroidism, similarly, we'll have to do calcium phosphorus levels. Then genetic and monogenic obesity, we'll have to do specific genetic tests as advised by the genetist. Then hypothalamic or pituitary disease, we'll have to do MRI brain. Then this is the last slide. Some red flag signs for pathological obesity. On the basis of our evaluation, we can diagnose these or look for these red flags. Early onset obesity is very dangerous. Very rapid gain in the weight in first few years of life. Then short stature for age or mid-parental height upon poor linear growth is a red flag sign. Then hyperphagia, non-discriminatory is a red flag sign. Then some presence of dysmorphic features is also a red flag sign. Then associated features like developmental delay, visual abnormalities, behavioral problems, then history of steroid use in the kid, and some hypogonadism if it is evident. These are the red flag signs for pathological obesity. Thank you. Thank you all for giving me this opportunity.
Wow, thank you. Thank you, Dr. Sachin, for being well in time also and for your excellent presentation. Now I request Dr. Rahul sir for your expert comments, please. Over to Dr. Rahul.
Sachin, it was very well presented. Just to give you from
Sachin sir, stop sharing.
Okay.
Just to add some few points to what Sachin had said. Like he rightly said, approach to obesity includes history, clinical examination, and then we go to lab investigations. In the history, he covered many points. Just to highlight, we start with the family history. Family history of obesity is many times seen in patients who are obese. Like my sir, Dr. Khadilkar, my teacher used to say, obesity runs in families where nobody runs. So that is what you actually see. If you have a child whose one parent is obese, then the child risk of child getting obesity is about 40%. And if both parents are obese, then it is significantly high. So family history of obesity is significantly important. Screen time, he did mention it. I'm sure the next speaker would cover it in details, but screen time is absolutely a must. Today's world, people have schools on laptops and mobiles where they are forced to sit in front of laptops, and then binging starts. Obesity happens because of excessive screen time. Babies who are born HGA are fed more, are likely to develop obesity at a younger age. Hence, history of HGA or preterm babies would be of help to us. Clinical syndromes like Prader-Willi would not be born as obese children. They would have hypotonia, difficulty in feeding, but that hyperphagia phase comes a bit later, where they start craving for food, and suddenly you see a child who is thin, lean, till yesterday, suddenly puts on weight significantly in the next couple of years. So those would give you a clue to in the history. Clinical examination, he rightly said, BMI is used as a parameter to classify overweight and obesity. It's a very simple way of doing it, where we use weight in kg upon height in meters square. A lot of us in our busy practice may not be able to do that. So the new chart, which has been published in IIP, the pediatrician friendly chart, has a box at the top where there are lines, and you can just plot the height and the weight, and you get an approximate BMI. May not be the actual figure, but it can be used to guide the parents about presence of obesity or overweight. Just a caution that if the extremes of age is 8 to 18 years, you may have difficulty interpreting it. So in those cases, please calculate the BMI yourself. BMI generally is used to classify, but there are certain conditions where BMI may not be actually useful. The drawback of BMI is that it does not differentiate between muscle and fat. So in case of central obesity, where you're expecting a risk of cardiometabolic risk being higher, only BMI may not be able to justify that. And in those situations, waist circumference could be of help to us. The waist circumference, more than 90% of the population and gender is considered as abnormal, but in Indian scenarios, we consider 70% because, like we discussed, we are short and tend to have central obesity. Nowadays, these centers were published by Dr. Khadilkar in 2014. And in 2018, we also have the wrist circumference charts, which nobody uses it, but if they are available, if somebody wants to use them, they can also be used as a screening tool for obesity and overweight children. Lab test, Dr. Sachin had a big list, which was rightly there. But remember, we do not have to do all the tests in all the patients. Depending on the clinical situations, the clinical findings, the anthropometrical findings, one could decide what tests to follow. In general, if a child of obesity walks in our OPD, what we do is we do a fasting lipid profile, a fasting insulin, a fasting sugar, and a HbA1c, which is fairly sufficient to diagnose the metabolic risk, and then we go out from there. I think that would be my take-home message. Thank you.
Great, sir. Great, sir. Thank you so much. We are
Tushar,
actually
you want to say something?
very fortunate to have.
Yeah.
Yes, Dr.
Yeah.
Tushar,
Tushar sir
please.
wants to say.
Just two quick comments. That HbA1c, please remember that the method you have to insist is the HPLC method, because nowadays there are point of care machines available everywhere and they give you falsely low readings. So please pay attention to the method. Secondly, insulin levels, although they are mentioned in a few documents, but we discourage pediatricians from doing fasting insulin levels, because particularly in adolescents, there is a large overlap between normal and abnormal values. Adolescence being a state of physiological insulin resistance, even normal adolescents will be having sometimes higher insulin levels. So it's best left to the researchers and endocrinologists. As a general pediatrician, yes, Dr. Rahul sir has already told us that lipid profile, fasting sugar, and HbA1c, blood pressure, and SGPT. Please remember. Yep. Thank you.
Yes. Thank you, Dr. Tushar. Now for the further proceedings, I hand over mic to Dr. Amruta Shirodkar, my co-host. Over to you, Amruta.
Thank you, Manjusha madam. We'll now move on to our third session for today. And the third session is on health consequences of obesity. And to present the same, we have with us Dr. Madhur Karwa. Dr. Madhur is a practicing pediatrician from Jalna. So over to you, Madhur. I think Pallavi madam, you will be sharing her PPT, right, from your end?
Yes, ma'am.
Yes. So kindly start the screen sharing.
Namaste and a very warm good evening to everyone. I shall try to cover my topic in time and explain it to the best of my knowledge. And at the outset, I want to thank Dr. Rahul Jahangirdar sir for his kind guidance. And I want to thank Dr. Manjusha ji, Dr. Amrita ji, and Dr. Kritika ji for the opportunity. So, as we all know, that obesity is emerging as one of the most serious health challenges of 21st century. And in the course of last few years, we have been seeing that childhood obesity has transformed from a sign of health and wealth to a sign of disease. Next, please, Pallavi ji. When everyone is sick, we no longer consider it as a disease. Next slide, please, ma'am. So this was the case scenario in our OPDs. We routinely see that आमचं बाळ तर लठ्ठ नाहीच. Parents are always in denial. Then we had an opportunity to host Dr. Tushar Godbole sir's lecture at Jalna, and he pressed the point that we should give it to them as well as us in black and white, so we can plot our patients on BMI charts and work accordingly. Next slide, please. I shall briefly touch the pathophysiology of childhood obesity in just a minute. As we can see, almost every organ system in the body is affected by obesity. One of the causative factors for all the complication is due to obesity-induced low-grade chronic inflammation. Then we can see there is CNS dysfunction, and again it is associated with low growth hormone, which again suppresses cognitive functions. Growth hormone is low, but insulin like growth factor 1 is normal, which again downregulates growth hormone, and the cascade keeps on going. We shall discuss this and more about each of these as we approach to the specific conditions caused or worsened by obesity. As we can see, many different factors contribute and interact with each other. Together, they form complex and vicious circles, which makes it difficult to evaluate the specific importance of any single causative factor. Next slide, please, ma'am. This is overall. We shall go one by one to one by one system. Next slide, please. Yes. This is a very important yet least addressed problem. Obese children go through bullying, both types of bullying, being bullied and bullying, both are common. Social isolation is very common. So are anxiety, depression, which in turn triggers eating disorders, reduced physical activity. Childhood obesity actually negatively affects cognitive functions, such as memory, executive function also, and the processing speed of the child. Here, again, growth hormone deficiency has been thought to be a causative factor. Studies have shown that obese children in general, yes, wait on the slide, please, ma'am. Obese children in general reach lower level of education as compared to normal weight peeps. Next slide, please. Glucose homeostasis is badly disturbed in obesity. What is insulin resistance? It is reduced glucose uptake even in presence of insulin. So when insulin release can no longer compensate for insulin resistance, type 2 diabetes occurs. There is resistance to effect of glucose that results in reduced glucose uptake in skeletal muscles and in adipocytes as well, and reduced suppression of hepatic glucose synthesis. Insulin resistance also increases adipocyte tissue activity, lipolysis, and all these factors taken together, there's elevated circulating insulin, glucose, as well as free fatty acid. Type 2 diabetes is has relatively more complication, and the complications are seen earlier as compared to type 1 diabetes. And I want to press the point that type 2 diabetes has never been seen in young adults and adolescents before the onset of obesity pandemic. TSH is also high due to obesity-induced thyroid gland dysfunction and increased turnover of thyroid hormones. As we often see precocious puberty in obese females because puberty occurs early in these females. Menstruation is also somewhat irregular. Obesity resistance seems to trigger hyperandrogenic state, which may trigger PCOS. Even in young adults, the fertility rate decreases. There is decreased fertility in boys as well as girls. And weight reduction has dramatic effect on all these problems. In boys, gynecomastia is common, and it also in turn affects psychosocial health of the child. In obesity, there is actually aromatization of testosterone to estrogen, and hence more estrogen in males. Next slide, please. Yes. Hypertension, we all know, is very common. It is increasing. Several factors come into play in addition to low-grade chronic inflammation. Hypercholesterolemia is thought to develop fatty streaks and associated with fatal heart disease in adulthood. Next slide, please. Pulmonary complications are common, obstructive sleep apnea, asthma, obesity has also been implicated in causative factors of asthma. Again, in obesity, there are sleep disturbances, lifestyle problems, decreased physical activity, which leads to sleep deprivation, and then activation of immune system. So these all things are bidirectional. Next slide, please. This is a major concern. It is well established in adults that increased BMI is associated with several types of cancers. And a recent study in UK has shown that obesity is responsible for almost 5% of cancer types. And thereby, this can be worked up because this is the largest modifiable risk factor for cancer. As in other diseases, again, chronic inflammation, altered endocrine patterns, alteration in growth hormones, secretion, along with metabolic derangement, which results in oxidative stress. These are the most commonly attributed factors for cancer etiology. Nowadays, a lot of research is going on microbes. Altered microbiome also contributes to causation of cancer. Next slide, please. There are neurological alterations in association with the cognitive disorders and what we have discussed. There is pseudotumor cerebri. Next slide, please. Impaired oral health is very important. This is because of local oral chronic inflammation and altered microbiome. Lower level of saliva in obese children and hence caries, and eating habits are also bad, hence caries.
Yeah.
And there is also association.
Dr. Madhur, you have 2 minutes left. Huh?
Okay,
Yeah.
yes. And there is also association between heart diseases and poor oral health. Next slide, please. This is my favorite slide. Immunological and autoimmune disease. When pathological amounts of fat gets deposited in adipose tissue, the fat cells become larger and a pathological immune activation takes place, and hence low-grade inflammation. Both cytokines secreted from adipocytes and increased macrophages and lymphocytes, they all and other immunologically active cells, they contribute to metabolic inflammation. Another important key player is cortisol, which is converted to cortisol and again immune system disorders. Multiple sclerosis is also said to be associated with obesity, and chronic inflammation is associated with multiple sclerosis, high prevalence of rheumatoid arthritis, SLE, inflammatory bowel diseases in obese children. Next slide, please. Again, insulin resistance is key factor in liver fatty liver development. It is the most common liver diseases in children, and insulin resistance and visceral adipose tissue is dominant source of fat accumulation in liver. Again, then vitamin D deficiency and multiple sclerosis and pre-diabetes has also been linked. These are all bidirectional correlation. Next slide, please. There is altered bone content, abnormal bone content, altered growth patterns due to vitamin D deficiency, inflammation, reduced physical activity. Next slide, please. Fractures are more common in these children. Maybe it is because of increased body mass, less physical activity. Acanthosis nigricans, very commonly seen, stretch marks, intertrigo, inflammation in skin folds. Next slide, please.
Dr. Madhur, your time is up. Please wrap it up soon. Yes.
It's over. These are the
Thank
problems.
you.
Last
Thank you.
slide, please. Yeah. So I just want to say, these are the gigantic problems our little children go through, and hence early identification, treatment, and support is crucial. So if we don't want to step into a future where there is productivity loss, disability, and premature mortality, let us take this issue seriously and start acting. Thank you for patient listening. Thank you.
Stop sharing the screen, madam.
Thank you, Dr. Madhur. I now request our expert, Dr. Rahul Jahagirdar, sir, to kindly give his expert comments.
That was extensively covered, Dr. Madhur. I just have 2 or 3 comments. Obesity is a chronic disease, and any medical condition which you have is made worse by obesity. The health implication of obesity can be broadly classified as immediate, intermediate, and long-term or long-acting, essentially including type 2 diabetes mellitus, hypertension, dyslipidemia. We could have coronary heart disease, respiratory problems, sleep disorders, orthopedic issues, or long-term implications involving depressions, learning disorders, and loss of self-esteem. So essentially, we could have every system which is involved, which she already has covered. So I'm not going to go in details about that. 2 points just to highlight what she was saying. Patients who have obesity have slightly advanced bone age. They tend to fuse early and they end up being slightly shorter, though in the normal target range which they have, but lesser than the potential which they would have grown if they were not obese. And secondly, one of the most important things which we many times see is the thyroid function test, which you rightly mentioned. So many times we get patients with a slightly abnormal TSH, so value around 7, 8, 9, with normal T3, T4 or free hormone levels, and somebody sends them to us as hypothyroidism. It is obesity-induced abnormal TSH because of resistance to TSH action or increased TRH drive secondary to leptin, which is produced because of obesity. And one has to be cautious while interpreting those reports, actually children are normal and not hypothyroid. I think I will stop at that and hand it over to the doctor. Thank you.
Thank you so much, sir. I think there were really useful points, especially the TSH interpretation in obesity and also the puberty, which can fuse the bones. Thank you so much, sir. With this, we now move on to our fourth talk for today. And our topic will be on prevention and management of obesity in primary care settings. And to deliver the same, we have with us Dr. Satish Gator. Dr. Satish is a pediatrician at Spurs Children Hospital from Akola. I would request Dr. Satish to kindly present his screen and start his presentation. Yeah.
Thank you so much, ma'am. Good evening, everyone. Myself, Dr. Satish Gator. I first of all thank you to IIP Maharashtra. And today's topic of my discussion will be prevention and management of the pediatric obesity in the primary care setting. So childhood is the critical period of the weight gain, hence ideal time for beginning of the prevention program. Prevention is the only sustainable option to decrease the comorbidities and the cost associated with the obesity. There should be a team approach involving the parents, school authorities, health provider, healthcare provider, media, and the government bodies. Spreading awareness regarding nutrition and the healthy lifestyle through the television program, articles in the newspaper, magazines, and health camps. So management strategies for the pediatric obesity. Childhood obesity is a great challenge for the pediatrician to manage. Essential steps of the management are recognizing the problem, setting goals, initiating the treatment strategies, proper implementation, and monitoring of the therapies. The cornerstone of the prevention is diet, exercise, behavior modification. As such, anorectic drugs and the bariatric surgeries are to be avoided in the management of the obesity, except in a rare life-threatening situations. Moving on to the diet, education of the parents and the children regarding need of the healthy diet for the growth and nutrition. Encourage small plate and small serving, avoid energy-dense food. Prohibit sales of the soft drinks, candies, sweets in the school canteen. Educate the parent that not to skip the morning breakfast. Improve the fiber intake in the diet. For more resistant cases and children with the medical complications, we have two approaches. One is by balanced hypocaloric diet and second is restricted protein sparing modified diet. So balanced hypocaloric diet contains 800 to 1800 calories per day depending upon the age and height of the child, or deficit of the 30 to 40% of the usual intake. It is low in fat with high complex carbohydrate, which allows to lose the weight slowly at about 0.5 kg per week, but grow normally. The food is given multiple serving under supervision by the family. The protein sparing modified fast, it is very low carbohydrate ketogenic diet, which includes high quality protein content, that is about 1.2 to 1.5 gram per kg per day, carbohydrate less than 20 to 30 gram per day, low fat intake of 10 to 20 gram per day, and a significant amount of water, vitamins, and mineral supplementation. Now, the advantage of the protein sparing modified fast is it has a protein sparing effect as it contains high amount of the amino acids. It induces smaller insulin response as it contains less carbohydrate and minimizing the anti-lipolytic effects of the insulin. So exercise. Lack of exercise and a sedentary lifestyle contribute more to weight gain in children than in adults. There are different types of the exercise which we'll see. So first of all, it is aerobic exercises. This type of exercises increases the heart rate and respiratory strength. Examples are dancing, basketball, volleyball, tennis, swimming, gymnastics, jumping rope, house cleaning, running, and cycling. Second is muscle strengthening. Examples are climbing a rope, tree, rock, push-ups, weightlifting. Third is bone strengthening exercises. These are recommended to perform at least 3 times weekly, 3 times a week. For example, jumping ropes, climbing mountain, walking, basketball, volleyball, running. Extension exercises causes muscle to become more elastic and there is less risk of injury. For example, yoga, dancing, and gymnastics. So there is something called FIT or FITT principle. It's a compatibility recommendation in exercise treatment in obesity. Frequency, it should be at least each day of the week. Intensity should be 55 to 90% of the maximum heart rate. Time should be 30 to 80 minutes. It should increase gradually, beginning 10 minutes of the walking 3 to 5 days a week and continuing 60 to 80 minutes almost every day. And type of exercises should be aerobic and resistant. This is the exercise program by applying the FITT principle. It includes cardiovascular program, interval program, and muscle resistance program. In cardiovascular program, the frequency should be more than 3 times a week. Intensity moderate to severe exercises. Time should be 20 to 60 minutes, and type of exercise will be running, jumping, biking, swimming, and so on. And the duration of the program should be 8 to 12 weeks. In interval program, the frequency should be more than 3 times a week, and the duration intensity should be 3 to 5 minutes of the mild to moderate exercises, interrupting for 6 to 8 times, and 1 to 3 minutes of the high intensity exercises. That is total 20 to 60 minutes of the exercise. And type of exercise: running, jumping, swimming, biking, and the duration is 6 to 12 weeks. And in muscle resistance program, the frequency should be 2 to 3 times a week, and the intensity should be high. And the time should be 2 to 3 minutes per muscle group, 8 to 20 repetitions, total more than 30 repetitions. Type of exercise: push-up, climbing, paddle. Program duration should be 6 to 12 weeks. This is a weekly activity pyramid. There should be less of TV and computer viewing. 2 to 3 swimming, paddle, tumbling, dancing, gymnastic, combat sport should be 2 to 3 times a week. Running, swimming, skateboard, climbing, skate, volleyball, basketball, soccer. This should be 3 to 5 times a week. And walking, using stair, cleaning the room, washing the plate, going to the market, this activity should be daily. So behavioral modification strategies: gaining insights into the child's problem by the pediatrician, getting the parents to be actively involved, and setting the realistic goal. Maintain the diet diary and exercise log. Counseling on the regular basis with plenty of the positive reinforcement. Encouragement and reward for the good performance by the child. Education regarding the calories, nutritive values, and other food options. Developing the daily exercise routine and increasing the energy expenditure. Building self-confidence and self-esteem, improving the attitude towards the food, exercise, and body image. As such, pharmacotherapy is not recommended for the appetite suppression in children, and use of such substances should be discouraged. Newer modalities of the leptin therapy is currently undergoing the human trial. Bariatric surgery is traditionally reserved for the obese adults with very high BMI for more than 40 kg per meter square or with comorbidities that are life-threatening. Thank you so much.
Thank you, Dr. Satish. You may stop sharing the screen, please.
Yeah.
Yeah, I think it was beautifully covered up, especially the exercise part. I would now hand over to the expert, Dr. Tushar Godbole, sir, for his expert comments, please.
Yeah, thank you, Dr. Satish. That was an excellent presentation. You almost made, you touched upon all the important aspects, although this could be a talk in itself. I mean, preventive strategies. And as rightly pointed out, the obesity is no longer seen in metro cities. It is seen in all strata and all parts of the country, be it any rural area also. We often take history and we ask them that whether your child eats any fast food or not, and parents are often defensive that we live in rural areas and we don't get such food such as pizza and burger. But we have to make them understand it is not just the pizza and burger. जिथे जिथे मोबाईलचा टॉवर आहे, जिथे जिथे मोबाईलची रेंज जाते, तिथे तिथे फास्ट फूड मिळतं. So we have to make them realize that 5 rupees and 10 rupee kurkure packet is available everywhere. Dr. Satish spoke about appetite suppressants. So I'll take the same cue and discourage the use of appetite stimulants. Until first 5 years of life, the parents will pester us to prescribe appetite stimulants, and that we should discourage. We should make use of the BMI curve. That's called as the BMI nadir, where the BMI actually goes down between the first birthday until the 5th birthday. Although we have the Indian BMI charts between 5 to 18, but if you follow the WHO charts of the BMI, you can see there is something called as a BMI nadir, where the fat percentage actually goes down between first and 4th birthday. So on the 4th birthday, the child is supposed to look as thin as Jungle Book ka Mowgli. That's my favorite example. So Jungle Book मध्ये मोगली कसा बारीक दिसतो 4-5 वर्षाचा. So तशी तुमची मुलं दिसले तर that's I think the primary prevention. If a child is fat on the 5th birthday, the child is going to remain fat forever. Lastly, so they often say that the appetite is not much, he does not eat much. So it's not merely the meals, but in between the meals, what is he consuming? For example, if the child is consuming 200 ml of buffalo milk, that comes out to be 250 kilocalories, which is equivalent to one meal for the child. So चपाती कम खाता है लेकिन आधा लीटर दूध पी लेता है. So that also has to be accounted for. Lastly, food should never be given as a reward, which is very, very typical in all the strata, including rural and urban. So not to give food as a reward is also very, very important. And all those things, kadhi paranta, until what time are we supposed to follow these? There is no answer to that. The entire family has to follow all the lifestyle modifications, not just the child. Yeah, thank you.
Great.
Thank you,
Great.
sir, for those valuable inputs. I think Dr. Ram Gopal sir wants to ask a question, sir, has raised his hand.
Yeah, thank you. My question to Dr. Tushar. See, we always say dietary advice whenever any talk. We always listen that. It looks fancy and it is easy to talk. But when it comes to the practical follow-up, what should we tell the parents? Because the next question comes, the child doesn't listen. So how to practically follow that dietary advice?
Yeah, I mean, children are like small monkeys, no? They would love to follow. So if we correct the dietary habits of the family, we don't have to actually talk to the child. The child will follow. So we have to, sit with the mother, maybe take help of our dietitian and formulate the week's, menus, the options. We can take the child's preferences, that on couple of days, we will also include the child's favorite food, so that the child also feels like being involved in the menu planning. But it's very important to sit with the mother and the child along with the dietitian to plan the week's menu. That helps.
So I understood. It's a dietary advice to the complete family, not for the child.
Absolutely.
Thank you, sir.
Sir, can I also ask a question? Sir, I just want to ask, sir, for less than 6 years now, ideally we don't advise any calorie restriction. I mean, we discussed a lot of diets in the talk. So then for those children who are obese less than 6 years, what should be our dietary advice? Of course, I mean, no junks and all goes into it. But should it be like increase more of exercise, activity, or like?
Yeah, I mean, Rahul sir would want to add to that, but even, I mean, not just less than 6 years, for pediatric obesity, as they are growing, we focus more on weight maintenance rather than weight loss. So we'll be happy if the child maintains weight. And often, if we can cut down the excess calories that come through the non-meal sources, it solves majority of the problem. Rahul sir wants to add to that?
Yeah, I absolutely agree with what Tushar has said. Managing obesity is really a nightmare many a times. You have that yo-yo effect. So a child with out of diet, exercise brings the weight, we bring the BMI down. And if he doesn't continue doing it, it goes back to the place where it was. This is because the set point is quite higher. So unless these factors of diet, intervention are continued by the family for a period of time, yo-yo effects are going to happen and we don't get our desired results. The latest guidelines have given a brief formula of 5, 2, 1, 0. All of you have read about it. The
Yes.
5 is what should the child be eating. So you should be eating 5 portions of fruits or vegetables in a day. 2 is less than 2 hours of screen time. 1 is 1 hour of exercise, and 0 is for sugar. So no added sugar in his diet. So we could explain this to the parents and hope they do the needful, and we definitely can impose this as a part of our practice.
One deadly habit is going on currently. 6 and 7-year-olds are going for tuitions. So if we can cut down those tuition time, that's also an idle time, sitting
Yes.
idle. We could reduce that as well.
Right, sir. Thank you so much,
Ultimately,
Tushar sir
parents
and
are
Rahul sir.
always. Yeah.
Yeah.
Amruta.
Okay. Yeah. Sure. Thank you, ma'am. So thank you, sir. With this, we'll move on to our last talk for today. Our last talk, the topic is comorbidities in obesity and surgical management of obesity in adolescents. For the same, we have Dr. Drakshani Gadve with us. She is assistant professor at Bharati Vidyapit Medical College, Sangli, and she's also a pediatrician at Shiv Sena Nursing Home and Gadve Children Hospital Clinic at Miraj. So over to you, Dr. Drakshani. You can share your screen. If you can start, it's visible in full screen.
Yes. Good evening, everybody. I thank MahaAP for giving me the opportunity, and also I thank Dr. Tushar sir for guiding me, and also thank Sangli IP for choosing me to give talk on this topic. I'll start with the session now. Today I'll talk about comorbidities in obesity and surgical management of obesity in adolescents. These comorbidities associated with obesity most commonly are high blood pressure, that is hypertension, and dyslipidemia, that is increased low density lipoprotein cholesterol and decreased high density lipoprotein cholesterol, and obstructive sleep apnea, type 2 diabetes mellitus, stroke, and some cancers, all these leading to poor quality of life. Some other comorbidities associated with reproductive system like precocious puberty, delayed puberty, PCOS type 2, menstrual irregularities, and heavy menstrual bleeding. So other system involving they will have joint problems in about 50% of the children, and they have arthritis in about 20 to 25% of the children. Most of the children, they have mental health issues like depression, about 70 to 90%, and stress incontinence, about 50%, and slipped capital femoral epiphysis. They will present with hip pain and difficulty in walking, and also they have non-alcoholic steatohepatitis. So coming to the pathophysiology, how the obesity or the overweight affects the cardiovascular health system. When there is this is a healthy artery, when there is unhealthy weight or increasing fat mass, that is overweight and obesity, there is increased cardiovascular risk factors like hypertension and hyperlipidemia. There is a new intima hyperplasia and atherosclerosis, which is leading to the heart arrhythmias, myocardial infarction, stroke, and heart failure. Coming to the pathophysiology, how obesity affects type 2 diabetes mellitus. There is an increase in appetite, decrease in exercise, increase in nutrient intake, and increased metabolic efficiency, which leads to increased adiposity, leading to insulin resistance and beta cell dysfunction. Here there is excess glucose production is there, but impaired glucose uptake and utilization, which is leading to the type 2 diabetes mellitus. But in obesity, there is a low-grade inflammation, reactive oxygen species, and dyslipidemia, adipokines, and beta cell stress, which also leads to insulin resistance, causing type 2 diabetes mellitus. Now, obesity is also associated with cancers type of cancer, mostly associated with colon cancer, ovarian cancer, breast cancer, esophageal cancer, gallbladder cancer, and involving other system also. So now looking for the pathophysiology, how it causes obstructive sleep apnea. When there is increase in subcutaneous fat and visceral fat, it pushes the diaphragm pushes upwards, causing the lung volume reduction. And also there is an upper airway obstruction due to fat, which is leading to obstructive sleep apnea in supine position. So now coming to the pathophysiology of how it is causing polycystic ovarian syndrome. When there is excess body fat, there is insulin resistance causing hyperinsulinemia, which causing decreased sex hormone binding globulin, leads to increase in androgen activity, leading to increasing luteinizing hormone, causing thicker cell hyperplasia in ovary, leading to anovulation. And hyperinsulinemia also causes increase in insulin-like growth factor, leading to anovulatory cycles. Now, after seeing all these comorbidities, now coming to the surgical therapies, when comorbid conditions associated with obesities, when they're not controlled with diet or lifestyle modifications, then we can go for bariatric surgeries. Bariatric surgery has been recognized by the National Institute of Health as an accepted and effective approach that provides consistent, permanent weight loss for clinically severe obese people or for obese people with significant complications of obesity. Traditional non-surgical treatment options and lifestyle and medical treatment, when they are not effective for long term for obese people, we can go for surgical therapy. And surgery, it improves the obesity, and also in some cases it can resolve comorbid conditions also. Surgery, we have to weigh the benefits of surgery versus the risk of staying morbidly obese. So the actual indications of surgery in obesity in adolescents are BMI of 40 or more, or BMI of 35 or higher with significant comorbidity. This is according to 2023 guidelines of IAP. And when there is a long-standing history of obesity and multiple unsuccessful attempts to lose weight using non-surgical methods, and ability to comply with dietary and behavioral changes as recommended by the weight management team. So types of surgeries available now are gastric bypass procedure, gastroplasty, gastric banding, partial biliopancreatic bypass procedure, and jejunal-ileal bypass. We'll see who is the ideal surgical candidate. The candidate who meets National Institute of Health criteria and there is no endocrine cause of obesity, and the candidate should understand the surgery and risk of surgery involved, and there should be absence of drug or alcohol problem, and there should be no any uncontrolled psychological problems, and it should consensus after multidisciplinary team evaluation by primary care clinician, bariatrician, surgeon, psychologist, dietitian, and exercise physiologist. And it should be well informed, motivated, and dedicated to lifestyle change and needs long-term follow-up. Actually, recently we had one child in Bharati Devpit Medical College, Sangli. Her age is 14-year-old female child with BMI of 69.3. Her weight was 152 kg and height is 148 centimeter. She had these comorbid conditions like type 2 diabetes mellitus, dyslipidemia, obstructive sleep apnea, and stress incontinence. I think she can go for bariatric surgery if not controlled by diet and lifestyle modifications. So coming to the surgeries, this is gastric bypass surgery. In this small part of the stomach is transferred into a pouch when here food enters from the esophagus into the pouch directly and directly into the small intestine bypassing the stomach. This is sleeves gastroplasty. Here, this procedure is done by endoscopically. Endoscopically, the volume of the stomach is reduced by taking sutures inside. So the amount of food entered into the stomach will be reduced. This is gastric band surgery. Here, the gastric band is tied around the stomach, and this is made up of silicone. We can loosen or tighten this band with a port connected to it subcutaneously so that we can control the amount of food entering into the stomach. The complications of this procedure are esophageal dilatation and erosion of the band in the stomach and band slippage and mostly sport infections. Now, duodenal switch surgery. In this surgery, there is a combination of two surgeries, that is gastroplasty, that is partially the stomach is resected, and also the duodenum is switched, forming the biliopancreatic loop. Here the food enters from the stomach directly into the small intestine, attaching into the common loop and colon. Now, this is jejunal-ileal bypass. Here, jejunum and ileal both are bypassed, and directly the small intestine is reattached near the colon, so that directly food and it bypasses the jejunum and ileum. Nowadays, this procedure is not performed because of severe adverse effects like protein calorie malnutrition, bacterial overgrowth, and migratory arthritis. In summary, these all surgeries are available, but in adolescents and pediatric age group, only the sleeve gastroplasty and also gastric bypass, these both surgeries are performed. Now, seeing after bariatric surgery, most of the medical comorbid conditions can be resolved. Type 2 diabetes up to 95%, hypercholesterolemia up to 97%, GRD 98%, stress incontinence 87%, sleep apnea 75%, hypertension 92%, and it improves cardiac function up to 95%. So take home message is avoid obesity, obesity associated with multiple system comorbidities. And if obesity is not controlled with medical, diet, and lifestyle modification, surgery is the savior. Thank you.
Thank you, Dr. Dakshani. That was perfect on-time presentation. You can stop sharing the screen. Thank you so much. I will hand it over to our expert, Dr. Tushar Godbole, sir, for his invaluable comments.
Thank you, Dr. Dakshani. You could summarize, a large topic in just 10 minutes. That's really commendable. Slipped capital femoral epiphysis is very common in obese boys, especially with delayed puberty. So if you're dealing with adolescent boys who haven't yet entered puberty, you should be really worried about the SCFE. And if you have SCFE on one side, it's always better to fix the other side also. So discuss this with the orthopedic colleague because the recurrence on the other side is common. Steatohepatitis very difficult to pick up unless you specifically ask for your SGPT. And if the SGPT is elevated, please ask for an ultrasound to look at the grading of the fatty liver. Most of the complications that happen due to obesity are it could be in the mechanical complications or the complications via insulin resistance. And the complications start much before the hyperglycemia starts actually. Even in type 2 diabetes, the complications have already started much before the hyperglycemia actually sets in, and that is because of the long-standing insulin resistance. Coming to the bariatric surgery part, yes, I have had only maybe 3 or 4 patients where we have subjected these adolescents to bariatric surgery. Most of them had type 2 diabetes that was really difficult to control. The moment we used to put them on insulin, the sugars used to get controlled, but they used to have weight gain. And the moment we used to stop insulin, the sugar started to rise. So in a couple of such cases, we subjected them to sleeve gastrectomy, and their insulin was stopped, and one of them became non-diabetic. Again, there is an expiry date for the bariatric surgery also. So the non-absorptive bariatric surgery, such as the sleeve gastrectomy, comes with an expiry date. So you have to make the patient understand that again, bariatric surgery is also not permanent. It gives you around 10 to 15 years of comorbidity free period, beyond which if you don't follow healthy lifestyle, again you are going to become obese and have all the problems. For hypothalamic kind of obesity and monogenic kind of obesity, you need not wait for the cutoff of 16 years or that completion of skeletal growth. You could subject these children to bariatric surgery much earlier because they are prone to complications much early. That's it from my side.
Thank you so much, sir. We have a couple of questions in the chat box. Can we just take that? I think 2-3 questions are there.
Yeah, please.
Yeah,
Please.
so we had one question that at what age can the children start gymming? Tushar sir, Rahul sir, anyone can take that.
Tushar, you want to take that?
Yeah, so they have tender bones, the ligaments. So definitely weight training is not recommended, but they could go to the gym and do non-weight training exercises such as stretching, cardio, self-weight exercises they could do. Any exercise with your own weight is perfectly fine. But if at all you have to, bear weights, it should not be more than 10% of your body weight. That's the general dictum. Rahul sir wants to add to that.
No, I agree with that. Resistance exercises to a minimal amount can be tried, but nothing beyond which can be more harmful than beneficial. Absolutely.
Right. And there was another question. If a child gains more than 2 kg in a year, is it an indication to investigate for any overweight issues?
I would not be going only by the weight. We would like to look
Right.
at everything else.
Right.
So if the other anthropometric parameters are corresponding to that and child is growing physically well, not be depending on child age as well. So if it is borderline puberty, peripubertal age and sudden weight gain, we would definitely investigate. Otherwise, we go with the anthropometry for the child over a period of time and intervene only if required. Tushar?
I agree.
Any questions from the audience? Do we have any more questions? So what about medical therapy? We have a few drugs which are recommended for adolescents. I mean, what are the criteria for putting the adolescents on medical therapy?
So for simple overweight, we discourage using drugs. For
Right.
obesity with comorbidities, we after initial 3 months of lifestyle modification, we subject them to drugs. The approved ones beyond 10 years are the orlistat, which is the intestinal lipase inhibitor. It gives you a nasty diarrhea, fatty stools. It's not very well tolerated, but it is an approved drug for obesity beyond 10 years. And the second set of drug is GLP-1 analogs that have been recently approved by FDA as a monotherapy for pediatric and adolescent obesity beyond 12 years, if I remember correctly. It's for adolescent obesity as a monotherapy. So in those drugs, we have an injectable drug such as liraglutide, which is a daily injection, and you have an oral drug called as semaglutide, which is available as an oral pill. It is often referred to as the medical bariatric surgery because it gives you results comparable to bariatric surgery, but you have to keep taking it until you're alive. You know, the moment you stop them, you will again become obese.
Right.
These drugs are not, I mean, not well tolerated. Many of them do have nausea, vomiting, and we have seen hospitalizations due to these kind of drugs. So they are to be, you know, tried under expert supervision only very, very gradually and after thorough evaluation and genuine attempt for the lifestyle modification. If it fails, of course, drugs could be used. Metformin is not the drug for obesity management, but all of us have been using metformin for insulin resistance, PCOS, pre-diabetes. We have been using metformin.
Just to add a point, only drugs would not help unless the other factors are considered. So diet, exercise, lifestyle modification go hand in hand with drugs. So somebody just start taking pills will not be benefited.
Right. So any role of
Dr.
topiramate?
Bhavish?
This is a question to Dr. Tushar and Dr. Rahul. Anybody can answer. So as a clinician, when can we start thinking about the genetic cause of a non-syndromic obese patient, particularly very young, like 8 months, 10 months, 12 months, 16 months? They have a weight of 12 kg, sometimes 14 kg, 15 kg, 16 kg, and they are non-syndromatic. So,
Tushar, want to take it?
Yeah. So any child who is born by consanguineous union, I would be thinking early onset obesity. So obesity starting between first year and fifth year. There is something called as constitutional obesity. We have been seeing it in exclusively breastfed children. They have the same history in the father or the mother. As you know, during infancy, the child is tall and obese, and beyond first birthday, the obesity kind of recedes. So I would be waiting until first birthday for a non-syndromic obese child to be sent for genetic evaluation.
Yeah, I agree with Tushar. There is something like catch up and catch down growth, which is happens in the first 2 years of life. Children tend to follow the genetic pattern or potential which they are born with. So we would definitely wait for a couple of years and monitor the child before we investigate them aggressively.
Thank you, sir. I think there are no more questions in the chat box. Any further questions?
One question more.
Let me congratulate the entire team. I think we had around 440 attendees on Zoom.
Yes.
Yeah, so congratulations to all of you.
Thank
Great
you, sir.
effort.
Thank you, viewers.
Highly
Thank you,
appreciated.
viewers, for excellent response. Yeah.
The first time on the MyIP
Great.
platform, on Zoom platform, we have 450.
Sir,
And another
on behalf of
approximate 50, another 50 on YouTube.
Congratulations
Sir,
all. Congratulations all. It
half
was wonderful
century.
session.
Thank you.
our experts
Yeah,
were very
thank
good
you,
and
thank
helpful all
you.
the time and very approachable. Thank you so much, sir, Rahul sir and Tushar sir.
Always a pleasure, madam. Thank you so much.
Thank you. I think we
Yours.
can,
That's
yeah, since there are no more questions, I would like to thank all the delegates who really joined in huge numbers, I think justifying the session on obesity today. Thank you all for joining in. I would also like to thank all the speakers who delivered really excellent talks and enlightened us. And my deepest gratitude to both our experts, Dr. Tushar Godbole sir and Dr. Rahul Jagedar sir, for their valuable inputs, expertise, and knowledge. And I also thank all the MahaIP team, the MahaIP Women's Committee team, and I thank our MMC observer. And thank you for that excellent session. And last but not the least, thank you, Pallavi madam, for the seamless conduct of the session over Zoom. Thank you, everyone.
And
thank you for
Dr.
joining
Amruta
in.
being there, moderating the session well. Thank you, Amruta.
My pleasure.
Thank you,
always.
Ram Gopal
Thank
sir.
you.
Thank you,
my